Heat-related illnesses are a preventable continuum of conditions, ranging from minor syndromes such as heat cramps, heat edema, heat rash, heat syncope, and heat stress. On a hot summer day, a runner in a marathon collapses on the side of the road. He's confused, disoriented, sweating profusely, and tachycardic. What is the most likely diagnosis and why? Think about this, and we'll come back to this case in a few minutes. These minor heat illnesses can progress to moderate heat illnesses such as heat exhaustion and eventually heat stroke, which can lead to multi-organ dysfunction and cardiac arrest. There are approximately 4,000 worldwide heat-related deaths yearly. 80% of those fatalities are elderly. Heat-related deaths occur in 5 per million over age 85, compared to only 1 per million in the 5 to age 44 group. Heat-related illness is the second leading cause of death among young athletes. The very young, less than age 4, are also at increased risk, with heat-related illness occurring in 0.3 per million compared to 0.05 per million in patients greater than age 4. There are multiple risk factors for developing a heat-related illness, including high temperature and high humidity, extremes of age, physical condition and health problems, limited air movement, poor access to climate control, psychiatric illness or psychosocial challenges, medications, not enough fluid intake, direct sun exposure, physical exertion, pregnancy, previous heat-related illness, and protective clothing. Let's do a case. Returning to the previous case, on a hot summer day, a runner in a marathon collapses on the side of the road. He's confused, disoriented, sweating profusely, and tachycardic. What is the most likely diagnosis and why? The answer is heat stroke. When evaluated by the medical officials, this patient was found to be hyperthermic with an altered mental status. The altered mental status is the key here. Heat stroke is a medical emergency defined as a core temperature greater than 40 degrees Celsius, which is 104 degrees Fahrenheit, as well as altered mental status or central nervous system dysfunction. CNS dysfunction can include ataxia, irritability, confusion. Heat stroke can eventually lead to multi-organ dysfunction, disseminated intravascular coagulation, and cardiac arrest. Heat stroke is a medical emergency, and mortality is estimated to range between 10 to 50%, and permanent neurologic injury is present in 20% of cases. Corey Stringer was an offensive tackle for the Minnesota Vikings who died of a heat stroke during a practice session during summer training in Louisiana. Team physicians mistakenly thought he had only experienced heat exhaustion because he was still profusely sweating, not realizing he actually had exertional heat stroke. The coaches and trainers were not taking into account acclimatization. So remember, the presence of sweating does not rule out heat stroke. People physiologically acclimatize to heat. It takes typically about 8 to 10 days, requiring about 1 to 1.5 hours of some form of exercise each day. During this time, individuals' sweat rate will double or even quadruple. Individuals with heat exposure can require from 5 to even 13 quarts of water per day, depending on the type of work they do. Salt consumption should be slightly increased to compensate for losses due to sweating. Acclimatization was well understood by the U.S. military. Prior to going to Iraq, they trained the soldiers in huge saunas, and the war was actually moved up to allow the soldiers to acclimatize. Despite this acclimatization, the majority of injury and illness in the first few months of the Iraq War was a result of heat-related illness. Heat stroke is divided into two categories: exertional heat stroke and classic non-exertional heat stroke. Exertional heat stroke occurs in individuals typically participating in exertional athletic events or demanding physical jobs in either temperate climates or in high ambient temperatures. The environment, use of gear, poor physical conditioning, and lack of heat acclimatization can all contribute to this. This type of heat injury tends to occur in younger, healthy individuals. Classic non-exertional heat injury usually occurs during times of high environmental heat and typically involves at-risk and vulnerable populations. Vulnerable populations include those with impaired abilities to thermoregulate, either due to age, the elderly or the very young, medications such as antipsychotics, amphetamines, anticholinergics, injuries such as burns, chronic disease, or psychological impairment. Patients on beta blockers are at higher risk for overheating as they cannot raise their cardiac output enough to efficiently increase blood flow to the skin. Although all these causes are different, the final pathways are eventually the same. In the case of the marathon runner who had collapsed with heat stroke, what is the most important initial treatment? While minor heat illnesses usually require no specific treatment other than removing the patient from the hot environment, a crucial component in the treatment of heat stroke is early and rapid cooling, preferably in the field. Ice water immersion is the most effective cooling for exertional heat injury in the pre-hospital setting. Although ice water immersion is the most effective cooling for exertional heat injury in the pre-hospital setting, in the emergency department, it's just not practical. It can be very difficult to examine, manage, and treat a patient who's submerged in a water bath, and we don't have access to these tubs while in the emergency department. A handheld fan and spray mister can go a long way towards keeping patients cooler. In patients with minor heat illnesses, the vital signs may be normal. Patients with moderate heat illness, such as heat exhaustion, may have mildly elevated temperature, mild tachycardia, and normal to mildly decreased blood pressure. The signs of central nervous system dysfunction, in combination with a core temperature greater than 40 degrees Celsius or 104 degrees Fahrenheit, are necessary to make the diagnosis of heat stroke. Circulatory collapse, including hypotension, can be present in 20 to 65% of patients with heat stroke. Remember to always consider other causes of altered mental status and elevated temperature, such as infectious etiologies, endocrine emergencies, toxicologic causes, malignant hyperthermia, and neuroleptic malignant syndrome. Let's do some trivia. What is the highest recorded air temperature on Earth? In 1922, a town in Libya recorded an air temperature of 57.8 degrees Celsius, 136 degrees Fahrenheit, which is considered to be the highest recorded air temperature reached on Earth. Body heat is regulated by four major mechanisms. Conduction, which is the transfer of heat via direct contact between two surfaces. Convection, which is the transfer of heat from a solid or liquid to a moving liquid or ambient air. This is what is referred to as wind chill. We have a thin layer of air that's on our skin all the time, and that air is heated by the skin and acts as a thin layer of insulation. That air stays with us all the time, unless of course there is wind. If the wind blows that air and therefore the heat away from the skin, then we cool down. Radiation, which is the heat that is emitted out of or off of an object. And evaporation, which is a change of state from liquid to gas. Circulation of air over the skin is necessary for evaporation. You can only lose heat through evaporation if the humidity is lower than the temperature of the body. With 100% humidity, the sweat on our skin cannot evaporate, and we are unable to cool through this evaporative process. The hypothalamus is the area of the brain that regulates the body's mechanism for cooling. When the core temperature becomes elevated, the hypothalamus signals for vasodilation and shunting of blood to the skin through sympathetic pathways to augment heat dissipation. This results in an increased heart rate and cardiac output. This is why patients with cardiac disease or those taking certain cardiac or blood pressure medications are at a higher risk for heat-related illness. There is a significant increase in sweat production. Therefore, dehydration can also predispose individuals to heat injury. This shunting of blood to the skin decreases blood flow to the kidneys and the gastrointestinal tract. Increased demand from decreased peripheral resistance causes a corresponding increase in cardiac output. At environmental temperatures above about 36 degrees Celsius, heat is lost exclusively by evaporation. At higher temperatures, heat is taken up by the body from the environment by radiation, conduction, and convection. Sweating then becomes profuse in order to maintain the balance between heat uptake and heat loss by evaporation. In order to be effective, sweat must be evaporated from the skin. If sweat merely drips from the surface of the skin or is wiped away, no heat will be lost. This occurs as the humidity approaches 100%. When water evaporates from the surface of the skin, this acts to cool the body. Evaporative heat loss occurs from the respiratory tract lining as well as from the skin. There is also a constant gradual loss of heat and water from the lungs and from the skin that is not related to the sweat glands. This is known as insensible losses. Sweating is an active process requiring energy and controlled by the sympathetic nervous system. When there is not enough blood flow to the skin stops functioning normally and sweating stops. As the ambient temperature and relative humidity increases, the evaporation and convection methods of body cooling become less effective. At 80 degrees Fahrenheit with 80% humidity, you are well into the danger range and at risk for heat-related illness. In such environments, or when conduction, convection, and radiation are inadequate to dissipate substantial metabolic heat loads, the only means for heat dissipation is by sweat evaporation. The rate of sweating increases directly with the ambient temperature. Hydration with salt solution is recommended. Gatorade or Powerade, though probably better to dilute the solution 50-50 with water, as many of these sports drinks contain a higher salt and sugar concentration than is actually needed. Conversely, if someone is drinking only large amounts of free water, this can eventually drop the serum sodium level, which can also result in an altered mental status and eventually seizures. If one cannot stay hydrated, sweating decreases and stops, as does the body's ability to cool effectively. The diagnosis of heat-related illness can be challenging due to the lack of strict diagnostic criteria other than that for heat stroke. There are 5 major types of heat emergencies: heat edema, cramps, exhaustion, syncope, and eventually stroke. Heat edema is a lower extremity dependent edema following heat exposure that is benign and self-limiting. Heat edema is the result of hydrostatic pressures, vascular leak, and cutaneous vasodilation. Mild heat-related illness can include a heat rash, edema, cramps, eventually syncope and exhaustion. These patients may have temperatures up to 40 degrees Celsius, may be tachycardic and diaphoretic, but maintain a normal mental status. Heat cramps are involuntary spasmodic contractions of skeletal muscle caused by a relative electrolyte deficiency in the muscle, most likely due to hyponatremia, low sodium. Rhabdomyolysis is a rare complication from sustained muscle contraction. These cramps are more likely to occur after the muscles have cooled. Muscular spasms that occur when the body loses too much salt during sweating, not enough salt is taken in, when calcium levels are low, or when too much water is consumed. Usually occur after exercise or after a latent period, on condition that non-acclimatized individuals are at high risk. The pathogenesis is thought to be due to a deficiency of sodium, potassium, and water at a cellular level, and the treatment includes rest and rehydration. Heat cramps typically occur in the extremities. Vital signs are typically normal, though the patient may be mildly tachycardic. Patients oftentimes feel dizzy and slightly nauseated, though mental status and core temperature are typically normal. The treatment of heat cramps includes rest, administration of an electrolyte solution orally, and it's best to avoid oral salt tablets, as this will often cause GI upset, nausea, and sometimes vomiting. Let's do some more trivia. So what do the Florida Gators have to do with heat-related illness? The name was derived from the school's football team, the Gators. Gatorade typically contains 110 milligrams of sodium, 30 milligrams of potassium, and a large amount of glucose, though it's generally accepted that actual Gatorade does have more glucose and sodium than is actually physiologically needed, and therefore a rehydration solution of 50-50 water and Gatorade or a similar rehydration salt solution is generally recommended. So when did Gatorade come on the market? Gatorade was first developed in 1965 by researchers at the University of Florida as a means to replenish the fluid, carbohydrates, and electrolytes that were lost from the body during physical exertion. Heat exhaustion results from exposure to high environmental heat or strenuous exertion and may progress to heat stroke unless the patient is removed from the hot environment and/or decreases their exertion and thermal regulation is not impaired. The most critical problem is dehydration. The systemic symptoms include tachycardia, weakness, syncope, nausea, and vomiting, and early intervention is key to preventing progression to heat stroke. Rarely, heat exhaustion may be complicated by rhabdomyolysis, acute renal failure, and even DIC. The symptoms of heat exhaustion can be very nonspecific and can include also headache and extreme weakness, fatigue, dizziness, fainting, decreased appetite, nausea, and vomiting. The patient may have a normal to slightly elevated body temperature. Symptoms can progress to syncope, orthostatic hypotension, diaphoresis, hyperthermia, and tachycardia. And the treatment includes rest, volume, and electrolyte replacement. The treatment of heat exhaustion is similar to that of heat cramps. Remove the patient from the environment, cool them, and administer an electrolyte solution or IV fluids as necessary. Heat syncope is an orthostatic syncope related to heat exposure that occurs in response to cutaneous vasodilation and the pooling of blood in the extremities. Heat syncope is characterized by a brief syncopal episode with a complete and rapid return to baseline. Consider heat syncope only in otherwise healthy patients with clear orthostatic causes. Syncope will often result from a cumulative effect of peripheral vasodilation, decreased vasomotor tone, and relative volume depletion, which can result in hypotension. This usually occurs in a non-acclimatized patient in the early stages of exposure. The diagnosis includes excluding more serious causes of syncope, and treatment includes rehydration, obvious removal from the environment, and rest. Heat stroke is the most severe form of heat-related illness and is defined as a body temperature higher than 41.1 degrees Celsius, which is 106 degrees Fahrenheit, and is associated with altered mental status or other neurologic dysfunction. The two primary forms of heat stroke are exertional heat stroke, which generally occurs in young individuals who engage in strenuous physical activity for a prolonged period of time in a hot environment, and classic non-exertional heat stroke, which more commonly affects sedentary, elderly individuals, persons who are chronically ill, and very young people. Classic non-exertional heat stroke occurs during environmental heat waves and is more common in areas that have not experienced a heat wave in many years. Both types of heat stroke are associated with a high morbidity and mortality, especially when therapy is delayed. Diaphoresis may be absent, but not always. Diaphoresis does not exclude heat stroke. Remember, the key is altered mental status. Anyone with elevated core body temperature and altered mental status should be considered to possibly have heat stroke until proven otherwise. Any other neurologic disturbance can also occur with heat stroke, and heat stroke can cause eventual brain damage, seizures, coma, and death. The differential diagnosis for heat stroke includes sepsis, drugs or toxins, infections, alcohol withdrawal, CNS abnormalities, thyrotoxicosis, and malignant hyperthermia. Consider sepsis, as it may be difficult or even impossible to differentiate between the two. Patients with heat stroke are often treated for possible sepsis at the same time. Excessive heat denatures proteins, destabilizes phospholipids and lipoproteins, and liquefies membrane lipids, leading to cardiovascular collapse, multi-organ failure, and ultimately death. Heat stroke can result in a total breakdown of thermoregulation and eventually multi-organ dysfunction. The organ that's most sensitive to heat is the brain. The brain is enclosed within the skull, which cannot radiate heat well through the bone. If you overheat the brain, it can take a long time to cool down. So the brain regulates heat by blood flow. Blood enters the brain at a lower temperature and exits at a higher temperature. However, in heat stroke, blood flow to the brain decreases. Therefore, if the temperature of the brain goes up, the brain will stay hot. Cerebral edema is common, and the cerebellum of the brain is highly sensitive to heat, often causing ataxia. Too much heat can trigger an inflammatory cascade, which is similar to sepsis, which can result in altered mental status, encephalopathy, seizures, coma, and death. In heat stroke, the metabolic rate goes way up. Heart rate and cardiac output increases until the patient goes into heart failure. The patient can develop cardiac arrhythmias, the conduction system starts to fail, and the patient starts having repolarization and conduction changes. The patient eventually brady's down and goes into arrest. Heat stroke will often cause liver enzymes to increase, and the gut ceases to work. Patients can also develop hematologic issues with microhemorrhages, thrombocytopenia, increased platelet aggregation, and DIC. Renal injury is common, secondary to muscle breakdown and rhabdomyolysis, resulting in myoglobinuria, acute tubular necrosis, and eventually renal failure. So how do we best treat these patients? The patients should be removed from the heat source, and initial intervention should include stabilization, monitoring of airway, breathing, and circulation, and rapid cooling. Patients with hemodynamic instability or altered mental status should be placed on a monitor and have continuous core temperature monitored with either a rectal, bladder, or esophageal probe. Rapid reduction of the core temperature is the primary goal of treatment. All heat-related emergencies should be placed in a cool environment as soon as possible. Ice baths are the fastest, but are often not practical. Many emergency departments do not have the baths, staff, or resources to practically utilize ice baths. One should begin cooling with cold ice packs to the axilla, groin, and neck. Fans and misting are often very helpful, though cold IV fluids do not seem to make a major difference. Tylenol and NSAIDs will often not work. So when do we stop cooling the patient? Active cooling should stop once the patient's core temperature has reached 101 degrees Fahrenheit. You've created a gradient, and the skin is now 50 degrees Fahrenheit, and the core will continue to drop for at least another 1 to 2 hours, and you may overshoot if you continue to cool the patient. Manage the airway based on the usual indications for intubation. Because mental status may improve with cooling, oxygen supplementation and/or airway support by using non-invasive ventilation techniques may support the patient's respiratory status while cooling measures are taken. Treat signs and symptoms of shock. Use IV fluid resuscitation with 1 to 2 liters of isotonic fluid to start. Reassess fluid status as the patient's temperature decreases. Although rarely necessary, consider vasopressors if the patient does not respond to IV fluid resuscitation. Don't forget to fully evaluate the patient and also treat other causes as you find them that may be related to altered mental status and increased core temperature. Remove the patient from the hot environment and provide rapid early cooling until the core temperature has reached 101 degrees Fahrenheit and avoid overcooling. Overcooling may also result in shivering, which may actually generate heat, raising the core temperature. Patients with minor heat illness usually do not require any laboratory or radiologic testing. A CBC, CMP, liver function tests, and urinalysis should be ordered in patients with suspected heat stroke. In patients with exertional heat stroke, a DIC screen and CPK levels should also be ordered. Laboratory and radiologic tests to rule out other causes of CNS dysfunction and elevated core temperature should be considered. An ECG should be ordered in patients with heat stroke, and radiologic studies should be ordered only as indicated by the patient's presentation and differential diagnosis. Here's some more trivia. What was the highest recorded human body temperature? The highest recorded core body temperature was 46.5 degrees Celsius, which was 115.7 degrees Fahrenheit. This occurred in Mr. Willie Jones on July 10, 1980. Mr. Jones was admitted to the hospital with heat stroke, and after 24 days in the hospital, he was eventually discharged. Although there have been case reports of patients with severe heat strokes surviving to discharge from the hospital, patients who remain comatose for over 24 hours will likely have a very poor neurologic outcome. Although there have been case reports of patients with severe heat strokes surviving to discharge from the hospital, patients who remain comatose for over 24 hours will likely have a very poor neurologic outcome. Test, test, test. Although there have been case reports of patients with severe heat stroke surviving to discharge from the hospital, patients who remain comatose for over 24 hours will likely have a very poor neurologic outcome. Let's review. With vital signs, temperature should always be taken via a rectal thermometer or bladder or esophageal probe. Continue to consider alternate differential diagnoses. And labs in mild cases are generally unnecessary and will likely be abnormal. However, in more severe cases, labs may have more utility as the disease progresses or improves. Cooling techniques include evaporative cooling by spraying with cool mists in front of cooling fans, and cold packs in the axilla and groin can be very effective. Ice baths should be considered only if evaporative cooling techniques are quite limited. Patients with heat stroke should be admitted and monitored for evidence of end organ damage. Unless there are other comorbidities, patients with mild heat-related illnesses may be discharged home following emergency department treatment. And remember that with heat-related illness, prevention is key.